So first, oxygenation. So what is new with pre-oxygenation, and what are some ways that we can help improve our patient's outcome? So we know that hypoxia is actually the most frequent complication that we see in emergency intubation. We've seen numbers anywhere from like 10 to 40% of patients with emergent intubations experience hypoxia. So we've been really pushing this over the last few years, having non-rebreather, turning it up to flush rate. We've talked about BiPAP and what patients could benefit from BiPAP. And then, when to bag patients using PEEP and then some apneic oxygenation. So let's talk about the patients that are at risk and how we can sort of expect who might desaturate and what those numbers are for EMS specifically. So this is a study published this year on desaturation in pre-hospital RSI. This was a helicopter study. So they took a database of a pretty big range of patient over several years, and they just looked back and said, how often did we see desaturation and in what patients, who's at risk for desaturation? So 19% was the number they came up with, which is pretty consistent with some other studies in that range. So about 1 in 5 of our patients are just going to desaturate while we're intubating. And it's not surprising that pre-intubation hypoxia was a big predictor, right? If you're already hypoxic and had to work really hard to get your sats up, you're probably going to be at risk for desaturation. But also increased body weight, so large body habitus. So our patients who have severe obesity have less functional reserve capacity. And so those patients, even when we pre-oxygenate them really well, they may desaturate quickly just because they don't have as much of a reservoir or reserve. Chest injury is one that came up, which I don't think this has been talked about well in sort of curriculum and literature. But if someone has, some splinting of their ribs because maybe they have some rib fractures, or someone has a hemothorax or a pneumothorax, like we're going to have trouble pre-oxygenating them, and that they're going to be at risk. So these patients have less alveolar recruitment. So keeping that in mind with our trauma patients. And then the one, I'm not really sure why the gender thing came up, but male gender was more likely to desaturate than the female gender. This may actually just be a byproduct of male patients experience more trauma. That's kind of what I speculate from this, but definitely an interesting note there. So of these patients who are at risk for desaturation, like what are we going to do about it, essentially? So this is definitely my favorite study that came out this year. It was really well done. But it was looking at non-invasive ventilation for pre-oxygenation during emergent intubations. So as we're going through studies today, I try to include as many pre-hospital studies as I can, but unfortunately, we are limited to what studies are being done. So there's some high quality studies that I'll include that are both ICU and ER. I would say the ER studies are probably the most closely related to the patients that you're taking care of, because you literally took care of them before they went to the ER. And then the patients in the ICU, they tend to have more rates of ARDS and things like that. So not all of that is totally applicable. So this study was called the pre-oxy trial. And you always remember a trial when they have a catchy name, right? So pre-oxy trial was basically comparing pre-oxygenation in patients that are ER and ICU. And they were looking at oxygen mask, which was mostly non-rebreathers, and non-invasive ventilation. This was a well-done trial because it was randomized, it was controlled. So you have the same number of patients in each arm. And what they included were just adult patients in this study. So 60% were men, 40% were women, and they were all critically ill. So they were undergoing intubation that was not elective. So intubation specifically in the ER or the ICU for these patients. So they did multiple centers. 7 of them were emergency departments. 17 of them were ICUs. So largely an ICU study. So something to keep in mind. And they randomized the patients, had them in parallel groups, which gives you a higher quality of evidence than some like observational data that we'll talk about later. And they had some exclusions. So for non-invasive, obviously the patient had to be breathing, right? They couldn't be included in these groups if they were apneic because they would require BVM. But they excluded patients who'd already been on positive pressure. So think of someone with a COPD exacerbation who's been on non-invasive for hours and hours, then they failed it and now they're intubated. Those were not the patients that they included here. And then also high risk of aspiration. So specifically, if you're actively vomiting, if you have epistaxis, if you're having any blood in the airway, something like that, they had to exclude them because of the high risk for non-invasive. So what they found out, and they were looking for SATs that dropped below 85. So they found out that the lowest SAT was about half as much in the non-invasive compared to the oxygen mask. So oxygen mask gave us that close to 20%, which is what we've seen in the other studies. But by using non-invasive in these patients, they got the hypoxia down to about 19 or 9%, which is pretty impressive. Like, this is pretty good data. It's important to note that they included all of the patients, regardless if they thought they needed alveolar recruitment or not. So classically, we've said, hey, use a non-rebreather for everyone. But if you think someone is at risk for hypoxia, consider non-invasive. So patients with CHF would be getting non-invasive. Patients who had refractory hypoxia with a non-rebreather. So this study is actually saying with all comers, they all did better getting non-invasive. And it was definitely clinically significant with that. Now, statistically, incidence of aspiration was very low, so there wasn't a statistical difference between the two. But I found it interesting that the oxygen mask actually had a higher rate of aspiration compared to non-invasive, because typically the argument against non-invasive is, oh, I'm worried they're going to aspirate. And so classically, we've taught, hey, if you have a patient who's a little bit confused, or maybe they vomited once, but they don't have persistent vomiting, instead of strapping on the non-invasive mask, just hold the mask, have someone hold the mask to their face so you're ready to manage their airway. But it turned out in that oxygen mask group, they had more incidents of needing to beg the people during the apneic period. So they pushed the meds, they desatted, they had to beg them. Whereas the non-invasive group, they just left them on the BiPAP, which I think this may have accounted for some of that reduction in aspiration risk, of just begging patients less. So interesting study. I definitely want to point out that most of these are ICU patients. That's who they saw the biggest difference in. But I think this is applicable and definitely supportive of the use of non-invasive. This study specifically was BiPAP. So they started at BiPAP, 10 of inspiratory pressure and 5 of expiratory pressure. So as best we can, if you have CPAP, we're trying to translate that a little bit. So I think the big take home for this is that non-invasive is going to give you better pre-oxygenation than a non-rebreather mask. Not saying that we have to use this for every single RSI, but this study definitely advocates the use. And I think if you have someone who's hitting one of those risk factors who doesn't have a strong contraindication, that non-invasive is a great way to go to give our patients a little more safe apnea time. So next, let's talk about BVM. And this trial was looking at BVM and out-of-hospital cardiac arrest. So over the last few years, there's been a lot of talk about moving away from the standard adult BVM and using a child or a small adult BVM for cardiac arrest patients. The thought is that, over-ventilation kills, and maybe we're hyperventilating our cardiac arrest patients. So there's been some studies that have kind of favored this small BVM. So this study came out last year, so 2023. It was an observational trial. So again, it's important to look at and consider the type of data that we're looking at. The last trial was randomized and controlled, so each group is treated the same, essentially, whereas this is observational. So we're not controlling for outside factors. So this trial was comparing small adult to large adult bags, so not necessarily pediatric bags. And it was what we call a before and after trial. So they looked at a group of patients from 2015 to 2021 in out-of-hospital cardiac arrest. They said, well, the first 663 were using a large BVM, and then the next 1,300, the EMS system transitioned to the smaller BVM. So we have a lot more patients in the small BVM trial side of the study. So their primary outcome was ROSC. So this is what this was powered for specifically, was ROSC, and it was actually significantly worse in the small BVM group. So 40% ROSC in the big BVM versus 33% in the small BVM. But our good neurologic outcomes, so patients who walked out of the hospital who are walkie-talkie after a cardiac arrest, was pretty close. So this 7% versus 5% wasn't statistically significant. Now, interestingly, the big BVM had lower end tidal rates, so that makes sense, right? We're giving more minute ventilation potentially than the small BVM, but the small BVM was definitely within a normal limit. So the limitation of this study is we don't know what tidal volumes they gave. So minute ventilation is a product, right, of our rate and our tidal volume. So it wasn't clear between these groups if they were actually giving the different minute ventilation. You can speculate based on the CO2. So I think the take home for this study is we need some more evidence. I think really a randomized control trial would answer this question a little bit better. But right now, I'm not completely sold on the idea that a small BVM is better than a big BVM when it comes to cardiac arrest.
Missy, you have a
Yeah.
little notice at the bottom of your screen about sharing, and it's blocking some of your
Oh,
slides.
thanks. Oops. How's that?
Beautiful. Thank you.
Okay, awesome. And am I glitchy or do I have good connectivity? Because I can turn off my camera if I'm glitching at all.
I haven't noticed anything yet.
Okay, cool. Let me know. All right, so on the topic of BVM, I'm going to reach back a little ways to 2019 because this PREVENT trial has come up in some discussions in the literature. So I think it's an important one to circle back to. So this was an ICU trial. So I want to bring that to the attention of everyone. These are ICU patients. It was 100 or 403 of them. So kind of a moderate sized trial, not as big as some of the other ones that we've seen. But what they were looking at was the incidence of hypoxia from induction, so when you give the medications, to 2 minutes after the intubation. And the two arms that they looked at was patients getting bagged during that time and patients with apnea. And specifically, the apneic period was with or without apneic oxygenation. So they didn't control and say you need to use apneic oxygenation. So it was kind of a mixed bag of if they got APOX or not. So imagine you have a patient, they're breathing on their own, you pre-oxygenate them well, and then you push the meds, their breathing slows. So during that time, they did 2-person BVM, they had it set at 5 a PEEP, they were giving 10 breaths per minute. Why they only had 15 liters per minute, I'm not sure, but that was standardized across. So the important thing about this trial is these patients were in the ICU, and anyone who the provider thought was at risk for aspiration was excluded completely. So classically in rapid sequence intubation, we don't bag during the apneic period unless we need to for desaturation because we're worried about a risk of aspiration. So what this study found was if they bagged the patient through the apneic period, about 30% of the patients still had a SAT that dropped below 90. The lowest SAT, though, was between 87 and 99. So they kept their SATs up pretty well, on average, 96%. The aspiration rate was about 7%, and the mortality rate was 36%. This just tells you how sick this patient population was. Patients who are needing to be intubated in the ICU don't do great, especially in these 400 patients. So the patients who didn't get bagged, who just you gave them the induction med, you kept the mask on, you left maybe plus or minus APOX, those patients had a bit more hypoxia. So really not surprising. So 40% of those patients dropped below that 90% threshold they picked for this study. And the rate was actually 81 to 99%. So neither of these groups had profound hypoxia, which is something to think about. Everyone stayed above 80% at least. So on average, 93%. Most of these patients I would still consider a fairly safe apneic period. The aspiration risk in this group was 6%, and then the death rate was the same in both groups. So what I think the take home for this trial is if you have a patient who you can't get their SATs up, into the mid to high 90s before you push the induction meds, is gentle bagging in the apneic period is very appropriate. But this trial doesn't 100% translate to EMS because our patients puke, right? Pre-hospital patients, they all eat a big meal and then they call you. Whereas these patients are patients they knew hadn't eaten in a while. They've already come through the ER, and the ER notoriously loves to make people starve. So some people have speculated. Oops, someone's mic's on. I'm getting a bunch of background. Okay, I think it's fixed. So I wouldn't say that it's safe to beg every pre-hospital patient before you intubate them. I still think really good oxygenation beforehand, apneic oxygenation are reasonable in patients that are high risk for aspiration. But patients that are high risk for desaturation, those
Yeah, we have to
patients,
take draft.
I should beg them.